Okay, today we're going to talk about endocrine disorders. And basically, we will discuss diabetes and the different types of diabetes, the endocrine system HPA axis, and complications associated with diabetes, such as diabetes ketoacidosis. If you remember, you have the hypophysis, you have the adenohypophysis and the posterior hypophysis, which is the neurohypophysis. All the hormones that are secreted in the adenohypophysis will be ACTH, TSH, gonadotropin hormone, you have somatostatin, prolactin, FSH, and LH, including MSH as well for melanocytes. And in the posterior hypophysis or neurohypophysis, you have oxytocin and ADH, which is the antidiuretic hormone. Let's talk briefly about the endocrine system before we jump into diabetes and other disorders associated with it. Remember that the endocrine system coordinates functioning between different organs through the hormones, which are released basically in the bloodstream by the ducts. Once they're in the circulation, the hormones affect functions to the target organ because remember, you have the hypothalamus releasing the releasing hormone, then you have the hypophysis, which you would have the stimulating hormone, and then you have the target organ. That organ could be a paracrine or autocrine effect. Basically, peripheral endocrine organ functions are controlled to various degrees by the pituitary hormones. Some functions, for example, secreting of insulin by the pancreas, primarily controlled by the blood glucose levels. So once you have hypoglycemia, you send a positive feedback to the hypothalamus and hypophysis and as well to the pancreas to start releasing ACTH that would increase the blood glucose level. These are controlled to a minimal extent. Um, Secretion, for example, in the thyroid and other gonadal hormonal will secrete the TRH in the hypothalamus, then the TSH in the hypophysis, as well as the T3, T4 in the thyroid. So if you recall in pathophysiology, you had the positive and the negative feedback effect of the HPA axis. So the interaction between the hypothalamus and pituitary is a feedback control system. The hypothalamus received an input from virtually all other areas of the central nervous system and uses it to provide input to the pituitary. In response, the pituitary releases various hormones that stimulate certain endocrine glands throughout the body. Any changes in circulatory levels of these hormones produced by the endocrine gland are detected by the hypothalamus, which then increases or decreases the stimulation of the pituitary to maintain homeostasis. So the hypothalamus modulates the activity of the anterior and posterior pituitary. Neurohormones synthesized in the hypothalamus reach the anterior pituitary gland, which is the adenohypophysis, through a portal vascular system, and that regulates the synthesis of release of these 6 major hormones that you have right here. Virtually all hormones produced by the hypothalamus and the pituitary are released in a pulsatile fashion. Periods of such release are interspersed with periods of inactivity. Some hormones, for example the ACTH or growth hormone or prolactin, have a definitive circadian rhythm. Others, for example luteinizing hormone and follicular stimulating hormone, have month-long rhythm with superimposed circadian rhythms as well. So in the anterior pituitary hormone, you have the adrenocorticotropic hormone, which is the ACTH right here. Okay, also known as corticotropin releasing hormone, is the primary stimulator of ACTH release. But antidiuretic hormone plays a role during stress as well. ACTH induces the adrenal cortex to release cortisol and several other androgens. Circulating cortisol and other corticosteroids inhibit the release of corticotropic releasing hormone and ACTH, so having a negative feedback effect. Then you have the TSH hormone, which regulates the structure and function of the thyroid gland and stimulates the synthesis and release of the thyroid hormones. TSH synthesis and release are stimulated by the hypothalamus hormone, which is TRH, and suppressed by a negative feedback by circulating thyroid hormones. So whenever you have T3 and T4 elevated, that's going to send a negative feedback to the hypothalamus and to the hypophysis to stop the stimulation or release of TRH and TSH. Then you have the FSH and LH hormone, which are the luteinizing hormone and follicular stimulating hormone that control the production of the sex hormones. Synthesis and release of LH and FSH are stimulated by the GnRH, which is the gonadotropin releasing hormone, and those are suppressed by ovulation. In men, FSH or Sertoli cells produce the spermatogenesis, and the LH acts as Leydig cells of the testicles to stimulate testosterone. Then you have the growth hormone, which is right here. Stimulates somatic growth and regulates metabolism. The growth hormone releasing hormone, which is the GHRA, is the major stimulator, and somatostatin is the major inhibitor of the synthesis and release of gonadotropic hormone. Gonadotropic hormone also released and synthesizes insulin-like factor, also called somatostatin, which also control growth. The liver, as you could see here, is the major organ that participates in the production of these hormones. Is basically the major source. In addition, this insulin-like growth factor occurs in the muscle and plays a role in enhancing muscle strength. It is less under control of the gonadotropic hormone than is in the liver. So the metabolic effect of gonadotropic hormone has two aspects. Initially exerts insulin-like effect, increasing glucose uptake in muscle and fat, but also stimulates amino acid uptake and protein synthesis in the liver and the muscle. Also inhibits lipolysis in the adipose tissue. So when you get growth hormone, you get muscles, but you also decrease weight. In addition, there is inhibition of glucose uptake and use, so therefore patients might have increased glucose levels. It could cause lipolysis, as previously stated. Growth hormone levels increase during fasting, maintaining blood glucose levels and mobilizing fat. Production of growth hormone decreases with aging. Ghrelin, which is a hormone produced in the fundus of the stomach, also promotes the release of growth hormone by the pituitary. Then you have prolactin, okay, which is produced in the cells called lactotroph that constitutes about 30% of the cells on the anterior pituitary. The pituitary doubles in size with pregnancy, so largely because of hyperplasia and hypertrophic of this lactotroph ducts. The major function of the prolactin is stimulating milk production. Prolactin also is released during sexual activity and stress, so it may be a sensitive indicator of pituitary dysfunction. Prolactin is the hormone most commonly produced in excess by pituitary tumors. So whenever you have a compression of the pituitary gland by a tumor, you could have release of prolactin levels and galactorrhea. Then you have the posterior pituitary hormone that, in addition, before we go to the neurohypophysis, we have to mention all the hormones that are released in the anterior hypophysis. And there you have your melanocyte stimulating hormone, you have lipotrophin hormone, encéphalins, and endorphins as well. In the posterior pituitary, you only have oxytocin and ADH. And remember that oxytocin has two major targets. You have the myoepithelial cells of the breast that prepares the alveoli and the mammary gland for lactation. So sucking stimulates the production of oxytocin. The contraction causes milk to move from the alveoli to the sinuses for lactation. Oxytocin also stimulates contraction of the uterine smooth muscle. In addition, ADH acts primarily to promote water conservation by the kidney by increasing the permeability of the distal tubular epithelium to water. At high concentration, also ADH causes vasoconstriction. Like aldosterone, LDH plays an important role in maintaining fluid homeostasis and also cellular hydration. The main stimuli of ADH release is increased by osmotic pressure of water in the body. So whenever you have problems with water only, the osmoreceptors will catch that decrease of volume or excess of volume and will release or inhibit ADH. So the other major stimuli are volume depletion, as I said, that is sensed by the beta receptors in the left atrium, as well as the carotid sinus and aortic arch, if you remember that in patho. And that would send the release for the ADH to retain water. Other stimulants are pain, stress, emesis, hypoxia, exercise, hypoglycemia, and many other medications such as beta blockers and angiotensin inhibitors, etc. A lack of ADH, you would see later on, that causes diabetes insipidus, which is the inability to the kidney to respond normally to ADH, causing either central or nephrogenic diabetes insipidus. So this is an overview of the hormones and the HPA axis. Now, again, if we go one by one, this is the major target organs and their major functions. For example, the hypothalamus. Remember that the hypothalamus is the control system. It will release all the releasing hormones that will stimulate the pituitary. So, regulates hunger, thirst, sleep, basically all the functions of the rest of the organs by releasing their releasing hormone. Then the pituitary is the one that controls the endocrine and target organs. So basically, hypothalamus will release the releasing hormone for the pituitary to release the stimulating hormone and then target every single organ. If it's the thyroid for regulation of energy and metabolism, if it's the parathyroid for calcium metabolism, if it's the pancreas, for insulin and glucagon metabolism as well as protein and fats, carbohydrates. If it's the thymus, for example, any build resistance for disease and the immune system in the neonate. If it's the adrenal gland, basically water balance, blood pressure, as well as the release in the adrenal cortex for the cortisol and mineralocorticoids, which is ADH, as well as in the adrenal medulla for the release of catecholamines. In the ovaries, for example, is basically the sexual drive and all the ovulation, etc. Now let's talk about diabetes. What is diabetes? Diabetes, that is an impairment of insulin secretion and variable degrees of peripheral insulin resistance, leading to hyperglycemia. As we will see later on, you have different types of diabetes, but the main two that we already have studied several times is diabetes type 1 and diabetes type 2. So what is insulin? Insulin basically is the peptide hormone which is produced by the beta cells of the pancreas, and the main function is regulate the metabolism of carbohydrates and fats by promoting the absorption of glucose from the blood to skeletal muscles and fat tissue. If you have increased levels of blood glucose as any feedback mechanism in the HPA axis, you have hyperglycemia. There is release of insulin by the beta cells of the pancreas. That will produce exocytosis and improve the permeability of glucose and the uptake by the liver. In addition to that, if you have high levels of glucose, that will inhibit the glycogenolysis and gluconeogenesis. If you have blood glucose levels that are decreased, you're in hypoglycemia, that we'll also see later on. You have release of glucagon. So basically, there is activation of adenyl cyclase in the Krebs cycle that would increase the energy and ATP production. increasing the gluconeogenesis and glycogenolysis as well, improving the glucose released in plasma. So basically, as I said, the insulin binds to the receptors. They're released by the beta cells of the liver, of the pancreas, and then basically the main function is for the metabolism of carbohydrates and also promotes protein synthesis. Except in the presence of metabolic disorders, insulin is provided within the body in a constant proportion to remove excess of glucose from the blood. This could be done by glycogenolysis and by gluconeogenesis as well as glycogenolysis. If you remember, whenever you eat carbohydrates, a portion of it will be used for the metabolism and the rest will be stored in the liver in a form of glycogen. In case of emergency, that glycogen could be decomposed or broke down into a molecule of glucose. That is called glycogenolysis. Other hormones that participate in the metabolism of glucose are glucagon in the presence of hypoglycemia. That basically stimulates the breakdown of glucose, producing new sources of glucose by gluconeogenesis and glycogenolysis. Somatostatin basically inhibits secretion of insulin and glucagon. You have the catecholamines released by the adrenal medulla, which regulates glucometabolism and promotes as well glycogenolysis and lipolysis. Cortisol basically is released in response to hypoglycemia as well and heavy exercise. Remember that cortisol comes from the adrenal cortex and that promotes gluconeogenesis. So with epinephrine and norepinephrine, you're going to have high levels of glucose. With cortisol also, you're going to have high levels of glucose because it promotes gluconeogenesis. Neo means new and genesis means production. So a new production of or new sources of glucose formation by cortisol. In addition, inhibits the protein synthesis and promotes release of free fatty acids. So you're going to have hyperlipidemia with cortisol levels being elevated as well as hyperglycemia. But also, in addition to that, when you release cortisol and epinephrine, you might have also catabolism being elevated. So the patient might have a negative nitrogen balance. Growth hormone stimulates the cell growth and division and increased the rate of fat usages. We already went through all this hormone at the introduction, but just a brief addition to it. Thyroxine, which is at the level of the thyroid gland, basically stimulates the use of carbohydrates and energy, as well as lipids, carbohydrates, and protein. So, as I said, this is a constant negative feedback and positive feedback mechanism. So whenever you eat carbohydrates. That will stimulate the beta cells of the pancreas to release insulin. That insulin will uptake the glucose by the metabolism by the cells. Some of them will be used in the Krebs cycle to produce energy, and some others are stored in the liver as a form of glycogen to be converted into glucose in case of emergency. Others, in a minor quantity, are stored in the muscle as well. So that would increase the blood glucose levels in case of hypoglycemia, and the body will stay in homeostasis. If on the contrary the patient is hypoglycemic, then the pancreas will release alpha cells, will stimulate the alpha cells to release glucagon, and the glucagon will convert the glycogen that is stored in the liver into a form of glucose by glycogenolysis, increasing the blood glucose levels. So basically, again, diabetes is an insulin secretion that is impaired. Either you have completely lack by HLA mediated lack of production or resistance to the insulin, producing both hyperglycemia. So it's basically a metabolic disorder. It's characterized by hyperglycemia, by defects on insulin secretion and action. There are different types of diabetes. You have diabetes type 1 and diabetes type 2, which can be distinguished by a combination of features. The term that also describes the age onset, you could have juvenile or adult, or type of treatment, it could be insulin or non-insulin dependent. Impaired glucose regulation is also a classification. Is an intermediate possibility transition state between normal glucose metabolism and diabetes that becomes more common with aging. Diabetes is a significant risk factor, and impaired glucose regulation as well is a risk factor for production of diabetes that could be present for many years before the onset of diabetes. It is associated with an increase of risk of cardiovascular disease, as you know, and diabetes as well is associated with microvascular complications such as microalbuminuria and retinopathies. If you remember the signs and symptoms of diabetes, you have basically the polyuria, polydipsia, polyphagia, and also weight loss. The most common symptoms of diabetes are those of the hyperglycemia. You know that hyperglycemia is a hypertonic solution, so basically brings water into it, producing dehydration. And that's the reason why the patient is so thirsty and is urinating hyperosmotic urine. Mild hyperglycemia of early diabetes is often asymptomatic. Therefore, diagnosis might be delayed for many years, unfortunately. More significant hyperglycemia causes glycosuria. The glucose is a high molecular level that normally doesn't filter through the kidney, through the nephron. By having an excess of transport medium, the glucose was spilled in the urine and producing glomerular damage. At the same time, the glucose brings water with it, producing an osmotic diuresis that leads to urinary frequency, such as polyuria, and polydipsia that may progress to orthostatic hypotension and dehydration. Severe dehydration, that even though they're not the most common signs of hyperglycemia, is a consequence of it, could bring the patient with weakness, fatigue, and even altered mental status, even more in the elderly population. Symptoms may come and go as plasma glucose levels fluctuate. Polyphagia is another associated symptom, but it's not typically a primary patient's concern. Hyperglycemia can also cause weight loss, nausea, vomiting, blurred vision, and predispose patient to bacterial and fungal infections, so have that in mind. In most severe forms, as we will see, diabetes, mostly type 1, even though it could be present in both, could progress into diabetes ketoacidosis, or type 2 more commonly, even though it could exist in type 1, to a non-ketotic hypersmolar state that we will discuss here. That would lead to stupor, coma, and even death if it's not caught or treated on time. You know that the long-term effects of diabetes, yearly of poorly controlled hyperglycemia could lead to vascular complications that affect the small vessels, such as microvascular or macrovascular problems. The mechanisms by which vascular disease develop include glycosylation of serum and tissue proteins with formation of advanced glycation end products. Activation of protein kinase increases vascular permeability and causes endothelial injury. That leads to sorbitol accumulation, hypertension, dyslipidemias. That's the reason why in this PowerPoint we're going to talk about hyperlipidemia as well, even though it's not going to be discussed in details because we already did the rationale and explanation of the guideline of ATP3 and the update. In addition, patients can get microthrombosis, pro-inflammatories, and prothrombotic effects of hyperglycemia, such as retinopathies, The most common, which are retinopathy, nephropathy, and neuropathy. You know that microvascular diseases may also impair skin healing, so that even a minor break in the skin integrity can develop into a major ulcer that could become infected, most commonly in the lower extremities. Macrovascular complications include um, angina pectoris and myocardial infarctions. So you would see that in these metabolic disorders, we could bring back cardiovascular diseases and questions associated with it, because one of the major macrovascular diseases involves atherosclerosis of the large vessels. They could produce also transient ischemic attack and strokes and peripheral artery disease. So the long-term effects again could be micro and macro complications. For macro complications, it's very, very important to screen and diagnose patients. We could do fundoscopic examination to rule out diabetic retinopathy, which is the most common cause of adult blindness in the United States. Basically, what you would see is focal blurring, retinal detachment. You could see sclerosis, um, you could see neovascularizations as well, microaneurysms, more advanced proliferative disease could come with hemorrhages and macular edema. In diabetes nephropathy, basically is one of the leading causes of chronic kidney disease in the United States. And what you would see basically is glomerular filtration rate that is declining. You could see microalbuminuria if you do a 24-hour urine collection. Um, basically, if you do also a urine dipstick, it will be positive for proteins, more than 300 milligrams per day. Um, Treatment, remember that ACE inhibitors are the one, or ARBs, that will diminish the progression of this diabetic nephropathy. So ACE inhibitors or angiotensin II receptor blockers should be used to treat hypertension and the earliest sign of microalbuminuria, because this could lead to diabetic nephropathy as well as hypertensive nephropathy. In addition, patients could have radiculopathies. Um, they could complain with paresthesias, vibration or proprioception affected. Um, they could have also chakra joint, and this is basically due to nerve ischemia associated with hyperglycemia and all the metabolic changes that occurs in the nerve due to high levels of glucose. Patients could have orthostatic hypotension, they could have exercise intolerance, they could even have resting tachycardia, fecal incontinency, constipation, diarrhea, urinary incontinency, erectile dysfunction, um, associated just because of high levels of glucose. Remember, it's very important to do the diabetic food screening. Okay, for neuropathies, you could give SSRIs, um, and also carbamazepine is very good to diminish their neuropathy. You know already how to treat cardiomyopathies and angina pectoris and MI, which is basically a complication of diabetes. So these are all the microvasculars and macrovascular complications that you could see. As you could see in the eye, retinopathies, cataracts, glaucoma, kidney nephropathy. So this is the earliest sign of diabetes nephropathy, having high albumin levels, so microalbuminuria. And once you see that, most likely the patient has associated hypertension. You must put the patient on ACE inhibitors to avoid progression. Of course, control the glucose levels. Neuropathies and macrovascular diseases, patients could have a stroke, they could have angina or MI or CHF, and they could have peripheral vascular diseases. So today we will discuss type 1 diabetes, type 2 gestational, and late adult onset, and secondary as well as gestational briefly. What is metabolic syndrome? It used to be called syndrome X or insulin resistance syndrome. It's characterized by a large waist circumference, more than 40 inches in men and more than 35 in women. It's basically due to excess of abdominal fat. By hypertension, even though now by the new guideline JNC8, that number is not a hypertension anymore. High levels of triglycerides, greater than 150, and as well as fasting blood glucose levels greater than 100, and in addition, dyslipidemia. In developed countries, metabolic syndrome is a serious problem. Development of metabolic syndrome depends on distribution as well as amount of fat. Remember that the abdominal obesity, or they also called apple shape, is even worse and more dangerous, increases the risk of CAD more than if you are called a pear shape. Excess abdominal fat lead to excess of free fatty acid in the portal vein, increasing fat accumulation in the liver. Fat also accumulates in muscle, so provide insulin resistance with hyperinsulinemia. The glucose metabolism is impaired and dyslipidemias and hypertension will develop. In addition, these patients have serum uric acid levels that are typically elevated and increased for gout attacks. In addition, these patients have and are in constant prothrombotic state, so they have increased levels of fibrinogen and plasminogen activator inhibitor as the inflammatory state. Patients also have increased risk of obstructive sleep apnea. Other risks include chronic kidney disease and even low plasma testosterone and erectile dysfunction. So how do you basically diagnose metabolic syndrome? Is by waist circumference, by having fasting blood glucose levels elevated, by having hypertension, and even though it's a contradiction now, and also by lipid profiles. And how do you basically treat? By lifestyle modification, healthy diet and exercise, weight loss. In addition, you could incorporate metformin, and that's an insulin sensitizer, or you could include, as we will see, treatments for the type 2 diabetes. Rosiglitazone may be useful as well. Other cardiovascular factors must be discontinued, such as smoking cessation, and again, increased activity to reduce weight. So what is the criteria for testing a patient with diabetes? So basically, testing should be considered in all adults who are overweight. So if you are in the classification of metabolic syndrome, even if your BMI is greater than 25 and you have additional risk factors, you should be tested, even if you're asymptomatic. So if you have a first degree relative with diabetes, such as me, for example, my mother is diabetic, I should have more frequent testing. If you are a high risk race or ethnicity, if you belong to these group factors such as African American or you're a Latino, you should be tested. If you when you deliver, it was a macrosomic baby, more than 9 pounds, that is the high suspicious factor to be diagnosed with gestational diabetes, even though your blood glucose levels were not elevated. Even more, if you were diagnosed with gestational diabetes, that's a high risk factor to become a diabetic later on in life. If you're hypertensive or you're on therapy, if you're dyslipidemic, if you are polycystic ovarian syndrome, if your hemoglobin A1C is more than 5.7, or if you're glucose intolerant, or if you have any other conditions that could be associated with hyperglycemia, such as acanthosis nigricans, which is basically a hyperpigmentation of the skin produced by an autoimmune disease as well as diabetes. Any history of CVD also should be tested. So, once you are suspicious of being a diabetic, what is the guideline saying that you're positive you are diabetic until proven otherwise? What are the most relevant examinations that should be done for the diagnosis of diabetes? First, if you do a fasting blood glucose level and you are greater or equal than 126, you're diabetic. If you do hemoglobin A1C and you're greater or equal than 6.5, you're diabetic. Or if you do a 2 hours plasma glucose level after glucose tolerant test and is greater than 200, you're diabetic. Or if you do a random glucose level and is greater or equal than 200, you're diabetic. Again, in the absence of symptoms, you should confirm this by repeating the test. Now, basically, remember that hemoglobin A1C should be no more than 6.5, okay? Because remember that decreases the lifespan of the red blood cell. Normally, it's 120 days, so when the hemoglobin is glycosylated, basically reflects mainly the glucose levels for 2 to 3 months. So even if the patient is non-compliant, if you check the glucose levels, if the patient is non-compliant, or if they want to tell you, no, I'm doing the diet, and you want to really check if this is true, you should do hemoglobin A1C, because the glucose remains glycosylated in the erythrocyte for 2 to 3 months, and it would tell you the most accurate value. Remember, that's the form of hemoglobin that is measured primarily to identify the plasma glucose concentration over prolonged periods of time. Okay, basically the pathway by the hemoglobin, which is exposed to the glucose. The normal levels of glucose produce a normal amount of glycosylated hemoglobin. So the fraction of this glycosylated hemoglobin is the one that you are basically testing, and that serves as a marker of the average blood glucose levels over a period of 3 months. In diabetes mellitus, a higher amount of glycosylated hemoglobin indicates poor control that has been associated with high risk of cardiovascular disease, nephropathies, and retinopathies. For the glucose tolerant test, basically you have to be fasting, then you drink a load of glucose, and then you're tested after. If it's greater or equal than 200, you are diabetic. You could do a fasting blood glucose level that, remember, you must be fasting for 8 hours, and if it's greater than 126 or equal, you're diabetic. Or fasting postprandial glucose level with glycohemoglobin greater than 5.7 to 6.4, you are diabetic. So what else do you have to examine on the patient besides the glucose levels? Basically, the age and the onset of the diabetes. The more early onset, the more age related, the more possibility for complications to diabetes ketoacidosis, um, eating patterns of the patient. Sorry. Physical habits, if they are in the metabolic syndrome or not. I apologize. The education history, and prior treatments and respond to therapy. Any current treatments that they're on right now, any barriers for education and understanding? Have you had any DKA in the past? Any glucose monitoring? Any diary that you have brought to me today? Any episodes of hypoglycemia? In addition, have you developed, or let me just screen you out for possible complications? Do a fundoscopic examination to rule out retinopathy. Do at least a dipstick for albuminuria or 24-hour urine, or a renal ultrasound to rule out nephropathies. Uh, any autonomic neuropathy, any sexual dysfunction. Um, any cerebrovascular disease in the past, any EKG abnormalities or echocardiography abnormalities, etc. For the physical examination part, since metabolic syndrome is one of the most common risk factors, you should measure the BMI, the blood pressure, fundoscopic examination. In addition, you could do thyroid palpation. You could do the skin examination as well, to basically try to diagnose the acanthosis nigricans, which is no more than, again, it's a hyperpigmentation of the skin um, that is found most commonly in the folds. You could see it in the neck, you could see it in the groin, in the forehead, in the armpits. It's basically benign, um, but it could be malignant as well, but most commonly is benign. It's mostly related to endocrine disorders. Um, it could be associated with Addison's disease as well, with Cushing syndrome, with acromegaly, highly related to insulin resistance. Um, it could be related to glucocorticoid use, with growth hormone used. It could be malignant as well. And if it's malignant, it's basically a part of a paraneoplastic syndrome, most commonly associated with GI or GU cancers. Basically, when you have acanthosis nigricans, there is increased circulating insulin and also growth factor release. You should do a skin biopsy or a diagnostic test for endocrine disorders to rule out malignancy, or if it's related to this type of endocrine disorder, such as mainly diabetes. In addition to that, you should do a comprehensive food examination, send the patient to a podiatrist, check the pulses because of the possibility of PVD, um, and also sensation that could be impaired. Laboratory evaluation that you should do, basically hemoglobin A1C, that will give you the levels in for the past 3 months. Um, Fasting blood glucose levels, fasting lipids levels. So you should do a lipid profile, liver profile, because if you're going to start the patient on any medication orally or any statins or fibrinic acid, you should do liver function test as well. Also test the patient for albumin. Remember that albuminuria is the first initial presentation of nephropathies. Serum creatinine and GFR should be calculated as well, and look for other factors that could lead to diabetes, such as thyroid disorders as well. So what are the acceptable blood glucose levels by the American of Diabetes Association and guidelines? Is an overnight fast should be less than 140, so between 70 and 140. 1 hour after meal, no more than 180, and 2 hours after meal, no more than 160. So what is diabetes type 1? Diabetes type 1, remember, is an HLA related. It's also called, we used to call in the past juvenile onset. Um, remember that this is because it's HLA related. There is a destruction by the immune system of the pancreatic cells. Diabetes type 1 tends to be genetic, but it could also be associated with any disease process that could destroy the pancreas. So if a patient as an adult onset has pancreatitis, for example, or pancreatic cancer, they could also develop type 1 diabetes. It's most commonly associated in children and young adults, but again, it could also appear in adult onset after pancreatitis or pancreatic cancer. It's an autoimmune disorder. It's genetic. It could be also associated with environmental factors. Again, this is a type 4 hypersensitivity reaction due to cytotoxic T lymphocytes. The pancreatic cells become infiltrated with lymphocytes and produces an autoimmune reaction and destruction of the beta cells of the pancreas, Langerhans. Again, it's HLA linking, and even though there's an immune response that destroys lymphocyte T's and B's at the level of the pancreas, producing type 1 diabetes. It could be associated in addition to with viral infections as well. We went already through the symptoms of diabetes type 1, which are identical to type 2. Basically, it's polyuria, polydipsia, and polyphagia. In addition to that, you could get weight loss, fatigue, frequency or high risk for infectious. It's familial dependent, even though you could get it as an adult as well. Other symptoms, because it's an osmotic diuresis and there's an increase of GFR at night, you get nocturnal enuresis. You could get pruritus due to hyperglycemia, hypertonicity at the level of the skin, and dryness of the skin as well. Burning or tingling sensation in the extremities due to neuropathies. GU and Candidiasis is an opportunistic infection that appears in any autoimmune disease. And also remember microvascular and macrovascular complications associated with it. And we will discuss one of the major complications, which is diabetes ketoacidosis. In addition to that, you could get hypoglycemia. You could get, because the high glucose levels will bring our water with the dehydration, and all the signs and symptoms of dehydration that we already discussed. Many opportunistic infections, in addition, gram-negative anaerobic infections associated with sinusitis, otitis, urinary tract infections, including glomerulonephritis and osteomyelitis and sepsis. So what is diabetes ketoacidosis? Basically is a major complication of diabetes, most commonly associated with diabetes type 1, but it could be present in diabetes type 2 as well. What happens basically is an insulin deficiency that enhances lipolysis, and therefore patients would have increased fatty acid delivery, and patients would have ketone bodies being produced. So it's a metabolic complication of diabetes. Patients could get hyperglycemia, could get hyperketonemia and metabolic acidosis. And how do you get that? Let's go back a little bit to pathophysiology. If you remember, whenever you have insulin deficiency, that causes the body to metabolize triglycerides and amino acids. Go back in your mind to the Krebs cycle. You have the carbohydrates, you have the proteins, you have the lipids, right? Whenever you exhaust the usage of carbohydrates, or if the patient has prolonged fasting. In this case, this patient doesn't have a prolonged fasting, but the glucose levels is in plasma, and since the insulin is in charge of bringing the glucose inside the cell, and there's no insulin because it's deficient, even though the glucose levels are elevated in plasma, the cell is perceiving that there is a major starvation because there's nobody, a medium of transportation to bring that glucose inside the cell. So therefore, the body starts using or breaking down proteins and also lipids as a source of energy. So you remember in pathophysiology that whenever you break down proteins, you end up with ammonia, and when you break down lipids, you end up with ketone bodies, right? But those are emergency factors or emergency metabolites for the production of energy and for to nourish the cell. But in case of emergency, it's not enough to continue having the whole metabolic cycle. So therefore, the body switches from the aerobic metabolism into the anaerobic metabolism, producing not only acetones or ketone bodies, but also producing ammonia and lactic acid. Therefore, the patient goes into metabolic acidosis. So, serum levels of glycerol and free fatty acids rise because of the usage of lipolysis and proteolysis. Um, there is hepatic gluconeogenesis as well that tries to stimulate the production of glucagon to obtain more glucose, because the body, even though they have high levels of glucose in plasma, since there's no insulin, okay, the body's perceiving, well, I have no glucose, let me start producing more. So they start taking out all the glycogen that is stored in the liver as glycogenolysis to produce glucose. Well, it's not enough. I still don't have glucose inside my cell. Let me start producing new ways of glucose formation, such as glycogenolysis or gluconeogenesis by source of lipids and by source of protein. That will stimulate the mitochondria to start producing ketone bodies and ammonia. So insulin normally blocks ketogenesis by inhibiting the transport of all the derivatives that leads to anaerobic metabolism. But the problem is that there is no glucose enough in the cell to nourish the cell. So that creates a major metabolic acidosis. So acetones derive from the metabolism of acetic acid, and basically patients would get more hyperglycemia with more electrolyte imbalances, with excretion in plasma as well as in urine of ketone bodies, producing more osmotic diuresis due to hyperglycemia, leading to a marked urinary loss of water and electrolytes. In addition, urinary excretion of ketones obligates additional losses of sodium and potassium. Serum sodium fall, producing natriuresis, and that produces more water excretion. More potassium is lost in high quantities. So despite a significant total body deficit of potassium, the initial potassium is typically normally or elevated. Why? Because of the catabolism of cells and also from the metabolic acidosis. Potassium levels generally fall further during treatment as insulin therapy drives potassium inside the cell. If serum potassium is not monitored and replaced as needed, life-threatening hypokalemia may develop and patient can go into a cardiac arrest. So this is basically the explanation. There is high glucose levels in cell, but there's no insulin to bring that glucose inside the cell. So therefore you start breaking down lipids into lipolysis. You start breaking down all the free fatty acid. You start breaking down all the proteins into ammonia, and you get at the end a metabolite, which is acetone bodies. In addition to that, glucagon is released to start producing new formations of glucose, and you get elevated activity of carnitine, you get more free fatty acid and more metabolic acidosis by breaking down lipids. So again, hyperglycemia per se will produce increased plasma osmolality, and that will produce not only osmotic diuresis but also natriuresis by excretion of sodium. So that would lead the cell into dehydration. Volume contraction, patient will go into shock. Whenever you have hypovolemic shock, the kidneys will shut down, the prerenal arteriole will vasoconstrict, the glomerular filtration rate will be decreased. All the solutes and electrolytes that are supposed to be excreted by the kidney are retaining as well. Patients get metabolic acidosis. So you get metabolic acidosis from different sources. From the hyperkalemia that you get from not having a good GFR, from the lactic acidosis that you get from the anaerobic metabolism. So basically, the clinical presentation is exactly the same clinical presentation of diabetes. In addition to that, you have nausea and vomiting that puts into more risk the cell for dehydration, abdominal pain. You have altered mental status because you have metabolic acidosis. The pulmonary system is trying to compensate by having tachypnea or hyperventilation, which is no more than Kussmaul respiration, and eventually, if there is no appropriate treatment or diagnosis, the patient can go into coma due to severe acetonemia. Um, the patients can have major thermical effect. Um, they could have hypothermia, um, poor skin turgor because of dehydration. So basically, how do you diagnose this? Patients, when they are suspected for DKA, you do serum electrolytes, you do BUN and creatinine, glucose, ketones, and osmolality. The urine should be tested for ketones. Patient who appears significantly ill and those with positive ketones should have an ABG as well. DKA is diagnosed by an arterial pH of less than 7.30. Remember, these patients have metabolic acidosis with a high anion gap, more than 12. Serum ketones in the presence of hyperglycemia gives you a presumptive diagnosis. Um, in addition, signs and symptoms that we already discussed, if you want to do an EKG to see the changes of potassium level that you should already know. Other laboratory that you could see is hyponatremia. Because of dehydration, you would have an elevated urine and creatinine. Because of dehydration as well, you would have an elevated plasma osmolality. So, in addition, initial potassium level could be less than 4.5, normal or high. It really fluctuates. Major treatment is to rehydrate the patient. You must concentrate on providing what the patient is lacking, which is IV insulin. But remember, in order to give IV insulin, the serum potassium must be normal or at least more than 3.3. Why? Because if the patient has hypokalemia and you give IV insulin, that's going to bring more potassium inside the cell and the patient could arrest. So again, push IV fluids. There's a major protocol for that. Tons and tons of fluid is basically 1 liter per hour or faster as needed to raise the blood pressure. Uh, Remember that they have a major intravascular volume contraction, so the volume should be restored rapidly to raise blood pressure and ensure glomerular perfusion. Once the intravascular volume is restored, remaining total body water deficit are corrected more slowly, typically over 24 hours. You will learn that in 669. Initial volume repletion in adult is typically achieved by rapid IV infusion of 1 to 3 liters of normal saline, followed by 1 liter per hour or faster. Then correct the hyperglycemia. And how do you correct the hypoglycemia? Basically is by um, giving insulin. Insulin should be given at zero point 0.1 unit per kilo. IV bolus initially, followed by continuous infusion of the same zero point 0.1 unit per kilo per hour in normal saline. And remember, insulin should be withheld until serum potassium is greater than 3.3. Otherwise, you're going to provoke a profound hypokalemia and the patient could arrest. So there is several levels, but if you could see the main difference between DKA and HHS is that the glucose level normally never surpassed 600. Patients are metabolic acidosis for both of them. Um, in DKA, they tend to have more metabolic acidosis than in HHS. Why? Because you would see in HHS that they do not lack insulin. They have resistance to it. They do have insulin, and some of the glucose go inside the cell. So the shifting to the anaerobic metabolism is less in HHS than in DKA. And these patients normally don't spill ketones in urine or in plasma. Some could have it, but very, very, very small. Serum osmolality, both of them are dehydrated. Of course, HHS is more dehydrated than DKA. Why? Because of the values of glucose. The higher the glucose, the higher the osmotic effect, the higher the dehydration. These patients in DKA, they tend to be more metabolic acidosis, so the anion gap is greater than 12, but less than 12 or normal in HHS. Okay, so what do you see in the laboratory labs for DKA? Of course, either normal to high levels of potassium. You would have hyperosmolality. Leukocytosis is because it's just an inflammatory response, but it could be associated with sepsis, of course, but the DKA by itself gives you mild leukocytosis due to the inflammatory cascade that is triggered. But again, hyperosmolality. So the osmolality is greater than 300. So again, to concentrate on the treatment, fluid. You have to give fluid, and based on the protocol, once the blood glucose levels are less than 250, then you change from normal saline to D5.5 to prevent hypoglycemia. And again, you give insulin 0.1 unit per kilo of regular insulin IV bolus followed by the drip with the same correction, and the pH correction only if it's less than 7.1, because these patients are high risk for pulmonary edema, so you should not give sodium bicarbonate unless the pH is less than 7.1. Monitor potassium level. Remember, never, never give insulin if the potassium is less than 3.3, because you're going to provoke more hypokalemia and put this patient into coma and cardiac arrest. How do you monitor these patients? Basically, you have to monitor hemoglobin A1C for all of them, lipid panel, liver profile. If you're going to start medication for lipids, look for the urine spot or the 24-hour urine for microalbuminuria, basically to look for complications. BUN and creatinine for signs and symptoms of dehydration and nephropathies, thyroid levels, CBC, chest x-ray, etc. Basically, this is for complications of infection. Okay, so you have to look at the risk factors and try to correct those risk factors. Obesity, so lifestyle modifications, ketone presence, meaning that the patient is uh, not utilizing insulin properly, and patient is prone to DKA. Okay. So again, this is very repetitive. You have to prevent macro and microvascular complications. So monitor very closely every 3 months the hemoglobin A1C, lipid panels, and blood pressure as well. We went through the management of dyslipidemia in the prior guideline. Remember that if you are a CAD or CAD equivalent, you must be less than 100 or less than 70 by the new guideline. Even if you are a stroke, it's mandated to be less than 70. Um, you start lifestyle modification if this is not enough. Then, and if you come back with lipid levels greater than 130, then you start um, statins unless contraindicated, because remember your LDL is your goal, so you must be less than 100, or if you're over CVD, less than 70, and you must be on high dose statin until um, side effects come, which are basically rhabdomyolysis and myalgias or liver dysfunction, or if it's contraindicated. I'm not going to go through this because we already had a whole video presentation on the lipid guidelines. Okay, so if you're going to give insulin, what type of insulins can you give? You could give rapid acting, which are Humalog or Novolog. Okay, you could give short acting regular insulin. You could give intermediate acting or long acting. Intermediate is NPH, or long acting is Lantus or Levemir. So how do you administer insulin? So you have a conventional schedule or you have an intensive therapy schedule. The conventional schedule is basically a morning dose of 2/3 of NPH and 1/3 of regular, and with an evening dose of half NPH or half regular. So basically, you get the kilograms of the patient, right? And you start zero point 0.5 units per kilo per day. And basically, you get a total number, and you would give 2/3 of that number in the morning and 1/3 of that number in the evening. Now, this is very similar to type 1, so we're going to go through quickly. This is mainly statistics. Remember that type 2 is mostly in adult onset, um, but it's the most common. Even though it's HLA related, um, it could be also associated genetically. Um, it's mostly insulin resistance. It's not the inability to produce insulin. It's associated with older age and obesity and metabolic syndrome. Patients that have gestational diabetes could get diabetes type 2, or any impaired glucose metabolism, sedentary lifestyle. African Americans or Latinos or Indians have risk for type 2 diabetes, even though it could be present as well in children and adolescents due to the high increase in obesity nowadays. Now, its insulin resistance produces decreased uptake of glucose by the liver, increasing lipolysis. So these patients would have hyperglycemia not only, but also hyperlipidemia. In addition, remember, these patients will maintain, as well as type 1, into a prothrombotic state. So they could produce microthrombies and have DVTs and other CVAs, etc. Now, this tends to be, even though patients with type 2 diabetes could have DKA, it's not as common. These patients tend to be non-ketotic because remember, they do produce insulin, it's just that they are resistant to it. And because the body doesn't go to the anaerobic metabolism that easy, that's the reason why they're non-ketotic. They also have hyperglycemia. They have the same exact signs and symptoms and the most common complications as well. So the laboratories and diagnostic evaluations are exactly the same. So we're not going to discuss that. So now, how do you start treatment with diabetes? You could do like type 1. Of course, you're going to do lifestyle modifications, right? You could do monotherapy, you could do combination therapy of oral drugs only, or you could do combination therapy with oral drugs and insulin. So you must inquire exercise and try that the patient complies with it, because exercise not only lowers the blood glucose level but also improves the ability of the insulin to uptake. That reduces resistancy and reduces, of course, the risk of heart disease. So what are the agents that you have? You have the sulfonylurea, which is the most commonly prescribed. You have the biwanides, you have the meglitinides, and thiazolid whatever, and alpha glucosamide inhibitors. Okay. Um, Examples of biwanides is metformin, and the mechanism of action is that you must memorize the mechanism of action. Biwanides metformin inhibits the glucose production by the liver. You have the sulfonylurea, which is the second generation. Those are the glipizide, the glyburide. They increase insulin secretion. Look that this medication would increase insulin secretion, but metformin does not produce um, insulin. Basically, it's better uptake. Okay, um, they're a very good adjunct to sulfonylurea, but they can also be used alone, especially for obese patients. So whenever you want to use a medication for diabetics that the patient is obese, you use metformin. Okay, the sulfonylurea, those are the most widely prescribed. They stimulate the pancreas to release more insulin. Okay, then you have the meglitinides, which are also called alpha glucoside inhibitors. They basically they bind to disaccharides more readily than sucrose to absorb glucose at the level of the gut, and they also increase insulin secretion. Those are the nataglide and repaglanide. Then you have the thiazolidinediona. Well, I don't know how to pronounce that name. I always say glytazones. So the glytazones, they decrease gluconeogenesis. So basically what they do is they increase glucose uptake by the skeletal muscles. And examples of those are the rosiglitazone and pioglitazone. So those are the glitazones. So basically, when you have hyperglycemia, remember that you have several other hormones that are released, and also how do the medications act at the level of organs to uh, decrease the blood glucose level. So basically, sulfonylureas and meglitinides, you must memorize that those two are the only one that produce insulin secretion. Then you have the thiali, which are the glitazones. They produce a glucose uptake and utilization as well as metformin. So metformin and glitazones do not produce insulin secretion. Then you have the metformin that also produce a hepatic glucose uptake. So again, you could do initial monotherapy. You could do two drug combination, or you could do 3-drug combination and or combine them with insulin as well. Okay, so in addition, we have, before we go into complications that are very similar to type 1, you have the exena- exe- exenatide, which is Byetta. Is also an injectable form that mimics the excretion of insulin by the pancreas. You have the sitagliptin, which is Januvia, okay, and you have the pramlintine, which is Simlin, is an injectable form as well. Um, so basically, the major complications of um, diabetes type 2, again, even though is could be associated with type 1, is the hyperosmolar hyperglycemic state. You also have complications of cardiovascular disease as well as type 1, nephropathies, retinopathies, neuropathies, hypertension, MI, angina, etc. So before we go into the treatment for the complications, let's talk a little bit about the hyperosmolar hyperglycemic. Again, remember, these patients basically they also have high levels of glucose. They do have insulin, but the problem is resistancy. So it's a metabolic complication that is also characterized by hyperglycemia with extreme dehydration, hyperosmolality in plasma, and altered levels of consciousness. Precipitating factors, the same as type 1, could be any infectious process or any medical condition, any drugs that could impair the glucose metabolism, such as patients that are in diuretics or glucocorticoids, or just simply not adherence to treatment. Serum ketones are not present because the amount of insulin present in most patients with type 2 are adequate to suppress ketogenesis. Because symptoms of acidosis are not present, most patients endure a significant longer period of osmotic dehydration before presentation. So therefore, plasma levels are higher, 600, and dehydration is higher than DKA. Symptoms are exactly the same, okay, and how do you basically diagnose is exactly the same, but you're not going to see ketone levels. Now, how do you treat? Same. Basically, you give fluid. You have to give normal saline 1 liter IV over 30 minutes, then 1 liter per hour to raise blood pressure and improve circulation and urine output. That can be replaced to half normal saline when the blood pressure becomes normal and once the plasma glucose levels reach 250 or 300 in some protocols. The rate of infusion of IV fluid should be adjusted depending on blood pressure, cardiac status, and then you give insulin the same 0.1 unit per kilo IV bolus followed by 0.1 unit per kilo per hour infusion after the first liter of saline that has been infused. Remember, potassium level must be greater than 3.3 in order for you to start insulin. Otherwise, you must replace the potassium first before you give insulin. Okay? So basically, determine the status of dehydration, administer fluid, look if the patient is hemodynamically stable or if the patient is in shock. Look at the serum sodium concentration. We're going to see this in 669 to see if the patient is hyperosmotic or hypoosmotic or isoosmotic. Okay, once the glucose levels reaches 300, in some protocols 250, then you change to 5% dextrose with half normal saline, and you decrease the insulin to 0.05. This is the way of administration that you give the insulin as well, and also remember to check chemistry 7 every 2 to 4 hours until stable. Potassium must be greater than 3.3 before you give insulin. If the serum potassium is less, you hold the insulin and you have to give potassium 40 milliequivalents up to potassium 3.3, then you give insulin. If the potassium is more than 5, do not give potassium. Check the potassium every 2 hours. Okay, other forms of diabetes, we have the gestational diabetes. That is a condition basically that um, women, of course, must be pregnant, and there's high glucose levels. Uh, is caused when insulin receptors do not function properly. This is likely due to pregnancy-related factors such as the lactogen in the placenta that interferes with the susceptibility of insulin receptors. Um, is very common in African American and Hispano Latino. Um, very common in obese women as well, and with family history of diabetes. Um, the rest is statistics. Um, Other specific forms of diabetes, we will see that diabetes in the mature patients that have surgical conditions, surgical procedures, and the glucose levels is elevated. Patients that are in sepsis, and because there is the release of cortisol, there is elevation of glucose levels as well. You would see as well, for example, in patients that have Cushing's disease, they could also have diabetes. Now let's talk about latent autoimmune diabetes in adult. Um, this is basically a form of autoimmune disorders, uh, mostly related to type 1 diabetes. It's basically diagnosed in the older adult. It's also called slow onset type 1 diabetes, um, but it could also be present in type 2. Features for the presence of latent autoimmune diabetes of adult um, basically are um, exactly the same as regular diabetes with polyuria, polyphagia, blurred vision. It's very compared to childhood type 1 diabetes. If you don't remember, more or less the pathophysiology, uh, but occurs in adult, and of course it's a slower course of onset. Adult with late autoimmune diabetes may initially be diagnosed as type 2 based on their age as a equivocal factor, but these patients tend to have a strong family history and they tend to be obese. So the clinical presentation is more than 25 years old. Um, they have initial control achieved with diet alone or with hypoglycemic agents. Um, they could this problem could occur within months, uh, but can take years or more, and they have the same factors associated with type 1 diabetes. About 80% of adults are mistakenly diagnosed as type 2, um, but they tend to progress to needing insulin in their therapeutic schedule. So the risk progression is that patients have higher dosage of metformin being used, and metformin is the best treatment initially for this population because they tend to be obese, um, but they have an early introduction of insulin therapy. So it is estimated that more than 50% of persons diagnosed as having non-obese related type 2 diabetes may actually have late onset autoimmune disorder diabetes. This is basically produced by autoantibodies that destroy the cells of Langerhans, as well as C-peptide, the same as type 1 diabetes. Um, then you have MODI, which is maturity onset diabetes in the young, very, very similar. It's produced by mutations of the glucokinase that leads to insulin deficiency. Um, there are many subtypes, but basically these patients would have non-ketotic hyperglycemia, the same as type 2 diabetes, with a strong family history of diabetes as well. So you have a genetic predisposition. And features that are suggested to MODI are young onset, so less than 25. If you remember, the LADA is more than 25. This one is less than 25. There is strong family history of diabetes. There is sulfonylurea sensitivity. There is absence of resistance. There are different subtypes. You have the glucokinase MODI and the transcription factor MODI. Basically, both are phenotype induced. They're genetic. In addition, you could have MODI by um, any hepatocellular mutation. Other causes of diabetes could be due to, as previously stated, Cushing's syndrome. Remember that you have an excess of cortisol production, acromegaly of growth hormone, thyrotoxicosis because the excess in activity of metabolism or any condition that accelerates the metabolism will start consuming carbohydrates, lipids, and protein. Therefore, there is a major production of glucose by gluconeogenesis. Patients with pheochromocytomas as well. This is a constant. This is a tumor, malignant tumor in the adrenomedulla that will start producing catecholamines at high levels. Therefore, again, any under any stress level, patients will activate gluconeogenesis and start producing glucose. Any pancreatitis or any damage to the cells will produce insulin deficiency. Therefore, you could have hyperglycemia. Any mutations or alterations in the cellular metabolism could also alter the production of glucose and absorption as well. In addition to that, there are many medications that could increase glucose levels or affect the insulin production or resistance, and that includes the antipsychotics, beta blockers, calcium channel blockers, of course, corticosteroids, fluoroquinolones, niacin, phenothiazine, and protease inhibitors and thiazide diuretics. This is a very common question in pharmacology. Thiazide diuretics produce hyperlipidemia and produce hyperglycemia and produce hyperuricemia. In addition, we have another classification, which is the glucose intolerance. Those are called pre-diabetic patients. They basically have impaired glucose levels. They are between the ranges of before diabetes. So remember that fasting blood glucose levels greater or equal to 126 will make you a diabetic. So a patient with fasting glucose levels between 100 and 125 are glucose intolerant. And that could also lead you to high risk for developing type 2 diabetes. If you do a 2-hour postprandial tolerance test, if you're between 140 and 199, because remember, for diabetic, to be able to qualify as diabetic, you must be greater or equal than 200. So if you're between that, you're intolerant to glucose. So there is a high probability that these patients could go into diabetes type 2. So therefore, you should inquire the same lifestyle factor modification. Okay, now let's talk about Dawn phenomena and Somoji effect before we conclude. Somoji is basically a rebounding high blood glucose level uh, that responds to a prior hypoglycemic event. So patients normally go to bed. They have a hypoglycemia more or less around 3 o'clock in the morning, and because of that, there is the release of catecholamines that eventually would increase the glucose levels. So there's a nocturnal hypoglycemia that leads to a surge of counterregulatory hormones, which are catecholamines, rising blood sugar levels in the morning. So what you should do in these patients are to check a blood glucose at 3 o'clock in the morning, and if the glucose is low, that's the reason why they're getting hyperglycemic in the morning. And what you should do is to treat this patient, reduce the long-acting dose before going to bed. And the Dawn phenomenon is a little bit backwards. Um, Basically, it's an overnight tissue that becomes desensitized to insulin and therefore causes raises of blood glucose level. So, in other words, there is release of growth factor such as cortisol and glucagon, as well as in minor extent of epinephrine that would signal the liver to release glucose. Other causes of morning hypoglycemia may include insufficient insulin administration the night before. So in these patients with Dawn phenomena, what you would do is you check blood glucose levels at 3 o'clock in the morning, and if they're high, you basically would decrease the glucose level. Okay, so we finished diabetes, and that was the topic that was requested for further discussion before the examination. Thank you very much.